Okay, our next speaker is Associate Professor Matthew Foote, who is a radiation oncologist. He's a local to Brisbane. Having completed his specialist training in 2009, Dr. Foote is currently working at the Princess Alexandra and Greenslopes Hospital and has a special interest in stereotactic brain and body radiotherapy, neuro-oncology, head and neck cancer and cutaneous cancer. Dr. Foote's going to talk to us today about radiation therapy and stereotactic radiosurgery for brain tumours. Hopefully his talk will be sexy like the last one. Sexy radiotherapy.
I can only try, Marina, thanks. I can chat for a bit. Firstly, obviously Brisbane's my hometown, so for all of those that have come from interstate, a very warm welcome. It's great to see so many familiar faces and obviously colleagues that I haven't seen for quite a few years, so thank you for the invitation. So I think fortunately Dr. Saran has actually covered a little bit of my talk, so we may be able to save some time. An interesting story I can tell you is when I look around the clinicians that are here, Eng Soo Ko did her fellowship at Princess Margaret the year before I went, and Craig Getty and I were actually at Toronto at the same time. So it's interesting, all of the speakers, three of us were in Toronto at a very similar time, and I think that it does show the value in terms of us specialists going overseas and picking up new skills, and certainly many of us have been fortunate enough to spend time overseas. There we go, that looks familiar. So I'm going to speak about radiation therapy, but I guess more of a focus will be on the stereotactic treatment. Can I move it? Perfect. Whoop. So I think many of you know this, but in terms of radiation therapy, in its simple form, it's just high energy X-rays that are targeted towards tumours. And at a very basic level, the aim is to cause damage to the DNA of the tumour cell so that when it tries to divide, it dies. Dr. Saran has spoken about the types of radiation treatment, that being photons and protons. I just put these pictures up because many of you may not have seen the inside of a radiation room. So this is your standard linear accelerator. This is a specific machine called a CyberKnife. This is available in Western Australia. And this is what I do a lot of my work at PA on, which is the Gamma Knife, which is a specific machine for treating brain tumours and other brain conditions. There's now one in Melbourne and there's also one in Sydney. In terms of radiation therapy, I put this slide up just to highlight how it has evolved over the course of my career. And although this is not specifically to brain, this just shows that with improving technology, we're now able to target tumour more accurately. Now, I like Frank's picture of the panda, but this just goes to show you how eloquent we can direct dose that we can actually create picture. And obviously this is Albert Einstein. In terms of general trends that we've seen in radiation therapy, we've seen, certainly in the last 5 to 10 years, a shift where radiation therapy is not just delivered in your high volume teaching hospitals, it's now delivered closer to where people are, particularly in more regional settings. But what we've also seen is this evolution of precision radiation therapy, and this is just some data from PA showing this stereotactic, which is high precision radiation treatment. And we now, from when I started as a consultant 12 or 13 years ago, it was less than 1% of treatments. And now it's in busy centres, 30 to 40% of our workload. So we've certainly seen a paradigm shift in how we treat patients. Briefly, I'm going to talk about the management of primary brain tumours, stereotactic treatment for both secondaries and gliomas, and a little bit about some radiation therapy issues. Now, GBM, many of you are well aware of this term. Obviously, the name is too long for even me to say, so I just call it GBM as well. And I guess this is an MRI scan, and I put this up because this is what clinicians are looking at when we're seeing this condition. It even looks ugly on an MRI scan, and it certainly is a difficult condition. The way I describe it is it's a bit like an octopus. So what you see here is just the body, but there's these tentacles that spread out into the brain. Surgery is always the first port of call, obviously at least a biopsy so that we can get the tissue diagnosis, so we can make the diagnosis. And there is some evidence that if you can have a greater resection, that outcomes may be better. The standard of care for this condition is surgery, followed by radiation treatment and chemotherapy. And the chemotherapy of choice in this condition is a drug called temozolomide. And I put this slide up here. This is just like a radiation map. Dr. Sarin has shown it. So this is a GBM post-resection, then receiving radiotherapy. Older patients with GBM, now I know that term is sometimes a difficult one to define, but the reason it's important is genetically we know that as patients are older, GBMs are different and they can behave differently. And this slide is put up purely to show that there's parts of the brain where more extensive surgery is not possible. So this is what we would say is a very eloquent part of the brain. Surgery here would cause significant functional deficits for that person. And for that reason, a biopsy only was attained. This is another sequence on an MRI scan, and you see this white fluffy stuff. That shows the edema around the tumour. So many of these tumours cause a reaction in the brain such that there's a lot of swelling and edema that may require management with drugs or steroids. In older patients, there are a range of options which could include a shorter course of radiation, and there's a couple of different schedules there. There even is some evidence for using chemotherapy alone. Moving on to low-grade glioma, to be honest, I don't like the term low-grade glioma. Anything in the brain, people call this a benign condition, but anything in the brain that grows can cause significant issues. And I just put up a few slides to highlight just a couple of quick points. You see in this case, it just looks different to GBM. Rather than being a big lump in the brain, it's more insidious in the way it spreads through the brain. But what we're finding out, which is more significant, are these molecular factors, and this is what can often drive treatment and drive prognosis. And as you can see in this case, the pictures actually look very similar. But if we look at the different molecular profiles of these tumours, they will behave very differently, and the treatment may be very different despite them looking very similar on a scan. In terms of things that I've seen over the last 5 years, in terms of developments within treatment, obviously I think many of the developments have been in identifying those molecular targets and tailoring treatment to that. From a radiation therapy perspective, a lot of it has come in more advanced imaging and sequencing with new targets, and I'll talk about that in just a bit. In terms of the imaging, this is some interesting scans. So this is a more advanced MRI scan at the top. And the significance of this is sometimes dead tumour looks very similar to active tumour on an MRI scan. But these more advanced MRI techniques can now help us in deciding, is this more likely to be dead tumour or active tumour? So this shows perfusion or blood flow through that area. This is another scan called a PET scan, and there are some traces now that can do a very similar thing, deciding whether it's radiation changes or whether it's active tumour. So certainly it has been very important in the clinic in terms of decision making post-treatment. So moving on to stereotactic radiosurgery. So stereotactic radiosurgery has a big long name, but in actual, if you break it down, stereotactic, high precision, radiosurgery, high dose, small number of treatments. Different from standard radiation therapy in the sense that we're trying to cause what's called tissue ablation. So we're trying to basically zap it and ablate it, as opposed to radiotherapy where you're giving small doses over an extended period of time. So very different. It does typically require a relatively small and defined target. It's really been used historically, both in benign and a malignant setting, and in the malignant setting, predominantly brain secondaries. In Australia, this represents a significant proportion of patients who have advanced disease. These patients are now living longer because of the effectiveness of our systemic treatments, so chemotherapy, targeted therapy, immune therapy. Patients are living much longer, but it does increase the time at which they're at risk of developing brain secondaries. Also, MRI scans are more readily available, so we're actually picking up a lot of these tumours at an early stage before surgery is required. So in terms of historically, patients used to be treated with whole brain radiotherapy, so treating the whole brain with radiation therapy. It was effective in controlling those brain mets for a period of time, but it was at the risk or at the expense of significant side effects. If you could just move on to the next slide for me, please. It's not working. So, and most of those side effects were pretty significant for patients. Not just the hair loss and the irritated scalp, but the neurocognitive effects. So, the ability to multitask, short-term memory, motivation. So treating whole brain is not something that I like to do or do regularly, because now with technological advancements we're able to target individual tumours very, very readily, and the data now shows that we can treat up to 15 and it is superior to whole brain treatment. So most of my patients now would at least get an attempt to treat with radiosurgery or stereotactic radiosurgery for brain secondaries. There's a number of technologies that can do this that are available out there. The Gamma Knife at PA, about 60% of our workload would be treating brain secondaries, so that would equate to maybe 400 patients, 350 to 400 patients a year. At Greenslopes, this is a quite unique setup called HyperArc. It's a very efficient way to treat brain secondaries, where all of the secondaries can be treated in a few rotations of the machine around the brain. I'm going to just talk briefly about stereotactic radiosurgery in glioma, and the reason is most people are told, and many clinicians still believe, that once you have radiation once, you can't receive it again, and that's just actually not the case. When patients with high-grade glioma recur, there's no real standard treatment approach, and I know Craig will talk about trials, and if trials are available, certainly we would push or recommend that for our patients. But there's a range of chemotherapies, repeat surgery, targeted therapies like Avastin, but I'm going to speak about reirradiation. And this is something that our group has published on, and it does show that with reirradiation, patient survival is actually quite good compared to the other treatments that we have. And the fear with repeat radiation is causing radiation damage or radionecrosis. And I guess what we've highlighted is with these stereotactic approaches, so these highly focused radiation approaches for recurrent glioma, that not only can we control disease for a period of time, but it's actually very low rates of radiation damage from reirradiation. This is just to highlight some of the cases that we would see. This is a patient that had some recurrent disease in a surgically inaccessible location, had Gamma Knife in this case, and very good results. You can see some evolving treatment changes 8 months after Gamma Knife. If we go back to that slide where I showed you the perfusion scan, so that was the scan looking at the blood flow on the MRI scan, those changes were cold, so this was just treatment effects, not active tumour. And I'm sure Craig will speak about immunotherapy. I guess I put this slide up to highlight the fact that there is a lot of active research at the moment, and given the advances we've seen in other tumours with the combination of stereotactic treatment and immune therapy, naturally people have started looking at this in brain tumour. And certainly this is an early study. We certainly have some experience in looking at combination therapy, and this is a patient that I've treated with hyperarc, to what would usually be considered unfavourable recurrent disease, in the sense that, as you can see, there's multiple areas of enhancement, but this patient had been living with GBM for over 2 years, had immunotherapy, and then we did stereotactic treatment, and she had very good tumour control long term. In terms of survivorship, I guess I'm just putting up the range of things that can happen during a course of more standard radiation treatment as opposed to the stereotactic treatment. Headaches and nausea are somewhat common, often in the start of treatment, particularly if there's swelling, may require some steroids. Fatigue is something that's usually progressive through the course of a treatment. I put up the neurocognitive effects. Yes, radiation is responsible for neurocognitive effects, but there's actually good evidence to show that there's other things that are more impactful in terms of neurocognitive effects, and that's typically the tumour itself, more extensive surgery, anti-epileptics. So there's a range of things that add to that neurocognitive impact. And this is just to put up the range of treatments that may be recommended through a course of radiation treatment, particularly Panadol. Rarely do you need opiates, but sometimes steroid for swelling. In terms of ongoing effects post-treatment, I put this up because we've been involved in a bit of research, and there's a lot of good evidence now coming out about the role of exercise through radiation therapy. So certainly would recommend all of my patients engaging in exercise. Those that are more motivated, we actually would recommend an exercise physiologist. I'm doing some work with Tamara Owensworth out at Griffith about psychological support, in particular using telehealth platforms. We've got something just about to be published which does show a real benefit for patients and caregivers that engage in this telehealth service. So watch this space, and it's something that we're hopeful that we can roll out across a broader network. So just a few take-home messages. I think it's worth highlighting the technological advancements in radiotherapy, making it a very effective and safe treatment. Still has a significant role to play in both low and high-grade glioma. Highlighting the advances in imaging, which really has paralleled the advances in radiation therapy. That there is an increasing role for repeat radiotherapy in glioma, in particular the use of stereotactic techniques, and that there is a lot of active research in the survivorship considerations with both exercise and psychological support. So thank you for your attention.